everyone. Good evening. Myself, Dr. Priyanka, and I'm one of your mentors for Study EFOG. Today we'll be having the discussing the RRR series, that is YouTube series, which will focus the important topics for your EPCOG Part 1 exam. So today we'll be discussing regarding the urogynecology module. So do like, share, and subscribe StudyMEDIC channel, and also press the bell button icon to get the recent updates on the added videos. So always remember that ambition is the path to success and persistence is the vehicle you arrive in. So be consistent and keep practicing the questions, both the EMQs and SBAs, and definitely will pass the exam. So first in this today, what we'll do is today we'll be discussing 10 extended matching questions and also 10 single best answers, where we will cover the urogynecology module, the incontinence, the pelvic organ prolapse, and also we will also have study over the urodynamic case studies. So first, coming to the extended matching questions. So these are the options which will be given in the exam, and out of that, you have to select any one answer. The question will be given, and out of this, there will be one correct answer. So here, the scenario is that she is a 45-year-old woman and she has complaints of urgency and frequency of micturition. Also, she was diagnosed with overactive bladder and she was started on lifestyle measures and 6 weeks of bladder training, but there was only mild improvement with that. So what is your next management? So we know overactive bladder for any urogynecology case, the first line of management is always a lifestyle management. So lifestyle management can be in the form of doing a pelvic floor exercises, keeping a bladder diary. If they are having high BMI, then losing weight, even smoking can worsen the incontinence, so referring them to stop smoking. And also in case of overactive bladder, they will be also advised regarding the bladder training for 6 weeks. So as we know that in urge incontinence, there is what happens is there is sudden urge to pass urine, and before the patient reaches the toilet, there is leakage of urine. So here we know that the bladder controls the patient. So in bladder training, what happens is the patient controls the bladder. That is there will be periodic bathroom breaks, where and slowly they will be increasing in case of bladder training, where the patient trains the bladder, and this is the treatment of urge incontinence. So if these measures are failed, then the second management will be, of course, the medical management. So here, what will be our next management? So it will be medical management. So what are the medications that we give in case of overactive bladder? Are the anticholinergic medications. So we know in a case of an urge incontinence or overactive bladder, so what is the overactive bladder? The bladder is made up of detrusor muscle, and the detrusor muscle should relax during the storage phase. So there is storage phase and voiding phase, and it contracts during the voiding phase. So if the bladder has premature contractions during the muscle has premature contractions during the storage phase, then we tell that there is detrusor overactivity or there is overactive bladder. And the anticholinergic medications are given to cause the relaxation of the detrusor muscle. So the answer will be anticholinergic medications, where after 6 weeks of trying the bladder treatment, it is ineffective. So anticholinergic medications can be oxybutynin, where it is preferred if the patients are less than 65 years of age. It comes in the oral form, or if the patient is not tolerating oral, then it can be the local application. And there are other medications like tolterodine or dariphenacin, which are also preferred in case of elderly patients. And the last one is the mirabegron, but the mirabegron is usually contraindicated in patients with hypertension. So those women, the NICE guideline says that those women who do not benefit from the 6 weeks of bladder training, so they should be started on the anticholinergic medications. And they should also be told about the side effects of anticholinergic medications like dry mouth, and there can be either it is contraindicated in those patients with glaucoma. So these all should be told to the patient. Then coming to the next question. So these are the options, and The question is here, a 66-year-old woman, she has presented with painless hematuria. So the hematuria is there and it is painless, and it is since 3 months, and she also has cachexic, the neoplastic symptoms like weight loss and increased frequency of urination. And then followed by that, she had a cystoscopic done, which showed the following image. So this woman is like this image, the cystoscopy image is likely suggestive of a growth in the inside of bladder. And the main buzzword here is the painless hematuria, which is seen in case of the bladder carcinoma. So there we can there the usually the scenario will be, they will be having weight loss symptoms, and they will be having bladder symptoms. The urine analysis done, which can show up the presence of RBCs in the urine. So and painless hematuria, and in combination of this cystoscopy findings, so most likely she is suffering from bladder carcinoma. So big, and also she, along with that, she has clinical findings of neoplastic symptoms, that is decreased appetite, weight loss. So here the option is bladder carcinoma. Now, this is the third question, where it is a case of a prolapse options which are given. So here it is an 89-year-old woman. So she is senile and she is having multiple comorbidities. She has hypertension, she has chronic, she has COPD, and she has prosidentia. Prosidentia means she has stage 4 pelvic organ prolapse, and she is sexually inactive. So in exam, do remember, do read each and every word. There will be buzzwords given in the exam which will guide you towards the answer. Okay, so she has multiple comorbidities, she is sexually inactive, and she is also diabetic on treatment, and also she is having cardiac disease, and she is on warfarin. So and her examination reveals a small atrophic uterus, which is for according to her age, and there is a vaginal vault which is lying outside the introitus. She has prosidentia. So, what is the most appropriate surgical technique for her prolapse? So that we know that there are two types of procedures, that is the reconstructive and obliterative. But those who are having multiple comorbidities, those who are old, and especially those who are sexually inactive, in them, the most preferred technique is the colpocolysis. So what we do in the colpocolysis is, so because it is preferred in those with multiple comorbidities, and especially those who are sexually inactive, because here there is closure of the vaginal and the perineal incisions. So in the history, we should ask if they want to have a sexual function or not. Okay, because they won't be able to have. So colpocolysis is a perfect option for her, where we do the closure of the vaginal and perineal incisions. So, to summarize, there will be pelvic organ prolapse surgeries are divided into reconstructive and obliterative. So, obliterative is to close the vaginal and perineal incisions, and reconstructive, it depends upon the type of prolapse. So, if it's an anterior compartment, that is cystocele, it will be anterior repair. If it's posterior compartment, it is posterior colpoperineography. And if it's a uterine or apical prolapse, it will be either a hysterospexy or hysterectomy, or if it's a vault prolapse, it is a sacrospinous fixation, or abdominal sacrocolpopexy. Now, this is the fourth question, where she is a case where she has undergone already 68 years old, who has presented with post hysterectomy vault prolapse. No, she is undergoing vaginal hysterectomy for a second degree uterine prolapse, and also she has an anterior compartment prolapse, but no posterior compartment prolapse. So, what technique can be done to reduce the chances of post hysterectomy vault prolapse? So, they are asking, so what measures can be taken so she shouldn't have any recurrence of the prolapse? So here we know that there are certain options like mechalcaldoplasty, where we approximate the uterosacral ligaments using the continuous sutures to the vaginal vault as high as possible to prevent the occurrence of the vault prolapse. So here there are internal Meckel sutures given and external Meckel sutures given. So here it is the main aim is to approximate the uterosacral ligaments to the vaginal vault as high as possible, which will prevent the further development of vault prolapse. So now a 65-year-old woman presents with complete vaginal vault prolapse. And she had hysterectomy 10 years ago for fibroid uterus. So it's a post hysterectomy vault prolapse. And following this operation for correcting her prolapse, so she is, because we know if we correct the prolapse, so they may have some side effects, some risk like of occult stress urinary incontinence. So has been explained of this, that if she undergoes a wall prolapse operation, so there can be chance of having an occult incontinence, which will manifest as occult SUI. So she is asking, so is there any operative procedure which will help to reduce her chances of developing urinary incontinence? So what can be the most appropriate technique? So the surgical management of the incontinence can be in the form of colposuspension, Bush colposuspension, or there can be midurethral slings, or a transobturator tapes. So here along with the abdominal sacrocolpopexy, a colposuspension would be the best management for her. So here, what do we do in colposuspension? In SUI, what is the main problem is there is an intrinsic sphincter deficiency. So the intrinsic urethral sphincter, so there are sutures which are passed behind the bladder neck, that is the urethra, and they are approximated to the Cowper's ligament, that is the iliopectineal ligament, as you can see, and which will hold the proper the urethra in place. So that is the called as colposuspension, which is an effective measure to reduce the risk of post-operative occult SUI. So now these are the options which are given for the incontinent patient who has come with incontinence. So she's 76 years old, postmenopausal woman, and she complains of stress incontinence symptoms like cough, leakage of urine with cough and running. And her examination is unremarkable. Even the bloods are normal, but and her urinal analysis also is normal. So she has tried the first line, that is lifestyle measures, which has failed, and then she has underwent a urodynamic study, which shows the following. So what we can see here, so the in urodynamic study, there are three types of pressures: the P abdominal, which you can see in the red down, and P vesical pressure in the blue, and the pink is the P detrusor pressure. So we can see normally during the filling phase, there can be increase in the P vesical pressure, bladder pressure, but there shouldn't be any increase in the detrusor pressure. If the patient coughs, so there will be increase with the increase in the abdominal pressure along with the vesical pressure, and but there shouldn't be any leak. If the patient is not having any SUI, there shouldn't be any leak. But here you can see that there is increase in the bladder pressure, the blue one, and also there is increase in the abdominal pressure at that time. Probably the patient is coughing at that time, and during that time the patient is leaking the same time, means that the patient is having stress incontinence. And when it is shown on the urodynamic graph, we call it as a urodynamic stress incontinence. So that is the diagnosis in her case. So what is urodynamic stress incontinence? So stress, as the name suggests, so it is involuntary leakage of urine which happens during stress time. So during coughing or laughing or running or jumping, which will increase the stress and which can increase the abdominal pressure and cause leak, is called as stress incontinence. And a urodynamic diagnosis is, we call it as urodynamic stress incontinence. Then what is detrusor activity overactivity incontinence? It is also called as urge incontinence or wet detrusor activity sometimes. So here, when there is rise in the vesical pressure with rise in the detrusor pressure and with associated leak, okay, so that is called as detrusor overactivity incontinence. That is wet detrusor activity when it is associated with leak. But when it is not associated with leak, when there is increase in vesical pressure and increase in detrusor pressure the same time in the filling phase, which is abnormal, without any leak, then we call it as a detrusor overactivity. That is dry, even sometimes called as dry detrusor, detrusor overactivity. And the third type is there can be urodynamic mixed incontinence, where there can be symptoms. The patient can come with symptoms of both urge and the stress incontinence. Any one symptom may be predominating, and in the graph also there will be features of both incontinence. So now this is the second urodynamic graph where the patient complains of urgency and frequency, and on the here they have urge symptoms, and on urodynamic testing, so we can see the first sensation to void is at 100 ml and bladder capacity is 350 ml. So it is slightly reduced, and on provocation we can see detrusor contraction strongly associated during the filling phase, but with no leakage. So as I said in the last question, so detrusor muscle shouldn't contract during the filling phase. So it should contract in the voiding phase only. When there is voiding, when the voiding is happening, when the urination is happening, that is because the detrusor muscle contracts and then the urine leaks. Urination happens. But during the filling phase, when the bladder is filling, then there shouldn't be any detrusor contractions. But when it is present, then we have to see in the graph. As we can see here, the blue one is the vesical pressure, the red one is the abdominal pressure, and the green one is the detrusor pressure. So we can see in the filling phase that when there is rise in the vesical pressure, there is also rise in the detrusor pressure. So, but it is not associated with leak. So hence it is a dry detrusor activity, or we can simply call it as a detrusor activity. You may say that there is associated stress incontinence also, because there is abdominal pressure which is increasing with vesical pressure, but you can see that there is no cough. Okay, there is no there is no leaking which is written over there. So if there was leaking which was written over there, okay, let me show by the pointer. So if there was leaking over written over here, because the both are increased, so then we could have said that there is the case of a urodynamic stress incontinence. But there is no leak, means that probably that the patient had cough during that time when the patient had increased abdominal pressure. Yes, so the same thing. The diagnosis here is detrusor overactivity. Now these are the options, and the patient, her clinical scenario, she's 45 years old and she already had a surgery for incontinence. She had a tape surgery 10 years back, and now she's having complaints of stress incontinence. That is, she's having leaking on coughing, laughing, sneezing, and her her examination is unremarkable, and also the pelvic floor muscle tone is very good. So what is your initial management plan? So for her, she already had a surgery for incontinence which was failed, and now she has stress incontinence. So the next management would be to refer her to urodynamic study. So this is an important, according to NICE guidelines. So what are the indications for a urodynamic study? So it is usually done in case of a mixed incontinence, where it is urge predominant, not stress, where it is urge predominant mixed incontinence, or where the type is unclear. Also in cases of voiding dysfunction, in case if there is an anterior or apical prolapse, and in cases of a history of surgery for stress incontinence which has failed, as in this case. So if the patient comes for stress incontinence symptoms without any previous history of surgery, we do not refer them to urodynamic studies. In stress incontinence, only in case if it has they had previously failed surgery for the stress incontinence, then we refer them to urodynamic studies. Now, these are the options here. So what can be of this? We have to choose one answer. So here she is 66 years old lady who presents with difficulty in micturition, and she voids only 3 times a day with large volumes. So she voids less times, but when she voids, it is associated with very large volumes, and she doesn't have any symptoms of a stress or urge incontinence. And on urodynamic study, her flow rate is 3 ml per second. Her bladder capacity is 800 ml. Her voiding time is 320 seconds. And first desire to void is 400. Second desire to void is 600. And urgency at 800. So what is the most likely diagnosis? So she's here. There are some features which will suggest that there is a suspicion of obstruction, because she is avoiding less. But when she voids, there is associated with large volumes. Also, you can see that the flow rate is also less, which is highly suggestive of obstruction. And bladder capacity. So here, how much should be the bladder capacity? It should be maximum 400 to 600 ml. So her bladder capacity is increased, and also her first desire to void is 400 ml. So which should be normally 150 to 200 ml. And her urgency and second desire to void is 600 ml. So the maximum bladder capacity is 600. So it suggests that she has a large bladder capacity due to chronic retention, urinary retention, and it is most probably due to bladder outlet obstruction or poor detrusor function. So that is the diagnosis in her case. Now we have these options here, and she's a 41-year-old woman who presents with a long history of recurrent urinary tract infections, and also she has been treated with presumptive antibiotics when she lives abroad. So probably she was diagnosed with recurrent UTI and she was given antibiotics for the treatment. And then she has severe pain in the bladder area and also urinary urgency, but she does not have any leakage. And she also reports occasional hematuria that resolves spontaneously. And her urine cultures have been negative so far. So, what can be the diagnosis is in her case? So, in her case, it can be interstitial cystitis, which we also call that as a bladder pain syndrome. And the cystoscopy is recommended in case of interstitial cystitis. We know that bladder pain syndrome is a diagnosis of exclusion where we have to rule out other causes of chronic pelvic pain and also UTI symptoms, or sometimes irritable bowel syndrome can also present with chronic pelvic pain. Some STIs also can present with that. So we have to rule out other things, and their urine cultures will always be negative. They won't be having any UTI, and then we then label them as interstitial cystitis. And also we do a cystoscopy because there are some cystoscopic markers which suggest that there is interstitial cystitis. So what can be the marker? So here you can see that it is a healthy bladder, but in case of interstitial cystitis, there can be Hunner lesions, which are due to the engorged blood vessels. You can see the dark red spots over there, which are Hunner lesions. And also you can see glomerulations, which are also the hallmark of interstitial cystitis. Like they look like a raspberry lesions. They are also called as in case of interstitial cystitis. Now we will go to the single based answers. So here she is a case of she is 48 years old woman who complains of incomplete emptying of bowel sometimes and requiring digital evacuation. She otherwise has no urinary symptoms, and she has 6 kids all delivered vaginally, and the last child was delivered by instrumental delivery. Her BMI is 37. She suffers from COPD requiring management. So what is the etiological factor that is associated with increased risk of developing pelvic organ prolapse? So we know all the options that are given, that all are risk factors for developing a pelvic organ prolapse. But what is the strongest one? So strongest one is the of course the parity. Okay. So in the history, so that's why in urogynecology in history we ask regarding their menopausal status, their obstetric history, how many kids they have, and what was the mode of delivery, because vaginal delivery is known to increase the risk, and what was the birth weights of the baby, and was it a simple vaginal delivery or a uh, instrumental delivery. So all these things should be asked in detail because that are the risk factors. So here the answer would be parity. So we know the risk factors for developing prolapse can be pregnancy and childbirth, menopause, it can be aging or pelvic surgery or high BMI or chronic conditions like COPD. So anything that increases the abdominal pressure and puts strain on the pelvic floor muscles is associated with prolapse. So the most strongest risk factor for having a prolapse is a parity. Now, a 54-year-old woman has symptoms of urgency frequency of micturition, and she was diagnosed with overactive bladder. She has tried the lifestyle measures, the bladder training, anticholinergic medications, that is, medical management has also been failed, and she was then started on Botox 100 units. But for Botox, where to start, the patient should also know how to do this self-intermittent catheterization. So she was unable to perform the clean intermittent catheterization. So the question is, what invasive treatment for overactive bladder is suitable for those who cannot perform clean intermittent catheterization? So the next step after Botox is to do the percutaneous nerve stimulation. So those the indications for percutaneous nerve stimulation is it should be done by the multidisciplinary team, by the urogynecologist, and it should be done in case those who cannot perform clean intermittent catheterization, or where the overactive bladder has not responded to lifestyle measures and also medical management, that is the anticholinergic medications. So she is a 64-year-old woman who has been complaining of incomplete emptying of urine, and she suffers from chronic cough, and also she has bronchial asthma. Her BMI is 36. So she has all these factors for developing prolapse. So the question is, in the POPQ examination, what is the description of the point AA? So we know that there will be the AA point will be on the anterior vaginal wall, as you can see here, AA and BA. So there on the POPQ grid there are 9 points. on the anterior vaginal wall, there will be 3 points, the AA, BA, and the C. That is the cuff of, that is the most distal part of the cervix. And on the posterior vaginal wall, there will be AP, BP, and D. So in a post-hysterectomy status, the D point will be absent. So, and the GH is the genital hiatus, perineal body, and total vaginal length. So how do we measure prolapse? So we tell the patient to do Valsalva maneuver, and we measure all these points except the TVL, that is the total vaginal length, when it is measured when the prolapse is reduced. And what is AA is, it is on the anterior vaginal wall, and hymen is taken as a reference point. It is taken as 0, and 3 centimeters above the hymen point is the AA point. That is, it should be -3 in the case of a normal patient who does not have prolapse. It should be -3. But if there is prolapse, so it descends down, it can become -2, -1, or 0. Okay, or in the plus figures. So A is on the anterior vaginal wall, 3 centimeters proximal to the hymen, and AP is on 3 centimeters proximal to the hymen on the posterior vaginal wall. Whereas BA is the most distal part of the anterior vaginal wall, which is done on straining. So it should also correspond to AA point. That is, it should be -3 above the hymen. Same with the BP. And the more the negative numbers, that is, the less is the risk of having prolapse. So the more the positive, the more they come towards 0, or it is positive, means that there is a prolapse. Now there is a 38-year-old woman who presents with chronic pelvic pain, and her pain decreases after emptying the bladder. Okay, so she has a blood investigations done which are normal, and her urine analysis has no signs of UTI, and that's why a probable diagnosis of bladder pain syndrome is made. So what is the most likely factor which can be aggravating the bladder pain syndrome? So here again, all are the risk factors which can cause increased risk of bladder pain syndrome, but the most important factor known to increase the risk of bladder pain syndrome is stress. So this was a study conducted on 565 patients, and stress was found in almost 61%, followed by of the patients, followed by 50% had difficulty in sexual intercourse. So stress, that's why in lifestyle management of the bladder pain syndrome, stress relief is also provided to the patient, and they are also referred to for the cognitive behavioral therapy in case of bladder pain syndrome. Now, a 66-year-old woman has complaints of painless hematuria. So these are the buzzwords. There is painless hematuria. Her blood investigations, everything has been normal. She has frank hematuria, and she's a chronic smoker. We know for a bladder carcinoma, chronic smoking, that is a risk factor. And she's undergoing cystoscopy. So she wants to know what is the most common. Okay, they are asking what is the most common problem for a woman following cystoscopy. So all this can be happen after a cystoscopy, but the most common is to have mild burning or bleeding, which is expected after a cystoscopy, which is expected during micturition. So the risk with cystoscopy can be, the common can be, there can be mild burning or bleeding, or there can be occasional risk like infection, or there can be rare risk like temporary insertion of a catheter, or delayed bleeding requiring removal of clots, or there can be injury to the urethra, and sometimes bladder perforation. Now, a 55-year-old sexually active, okay, woman who is diagnosed with wall prolapse, and she had hysterectomy 10 years back for heavy menstrual bleeding. She is planned for abdominal sacrocolpopexy. So what is the main drawback of abdominal sacrocolpopexy over sacrospinous fixation? So why is she planned for abdominal sacrocolpopexy? Because she is sexually active, we know. Okay. So in them, always ASC is preferred than a sacrospinous fixation, because sacrospinous fixation, it will decrease the vaginal length. And those who already have a complaints of dyspareunia, or who are sexually active in them, it is usually not preferred. The abdominal sacrocolpopexy is preferred. So but it is a major abdominal procedure. So what can be the drawback is it can cause more overall morbidity. So yes, abdominal sacrocolpopexy has more morbidity than the sacrospinous fixation. Sacrospinous fixation has earlier recovery, earlier discharge from the hospital, and but it can worsen the dyspareunia in those who already have, because it will decrease the vaginal length. And also, so that's why it is not suitable for those who complain of dyspareunia or who have short vaginal length. And abdominal sacrocolpopexy, on the other side, they can cause overall mobility is more, but the recurrence of wall prolapse is less than sacrocolpopexy. And there is high satisfaction rate. Now, a 46-year-old woman is undergoing sacrospinous fixation for wall prolapse and wants to know the risk associated with it. Okay, so she's undergoing sacrospinous fixation. So, what now is susceptible to entrapment during the sacrospinous fixation? So it is the pudendal nerve because as we know the anatomy, so it runs behind the lateral third of the sacrospinous ligament and ischial spine and along the internal pudendal artery. So this nerve is susceptible for damage during the case of sacrospinous fixation. You can see. So because it passes behind the sacrospinous ligament. So 45-year-old woman attends the general gynae clinic with complaints of urgency, frequency, and urge incontinence. And she doesn't have any significant past medical history and she's not taking any medications. Her all the investigations have been normal. But she also reports of fecal incontinence. So how you will manage her? Along with the urgency, frequency, and urge incontinence, she has fecal incontinence. So this is a case like of a complicated type of incontinence where the pelvic floor exercises won't help. Even the oxytocin, it is an anti-muscarinic agent, so it won't help for fecal incontinence or a desmopressin, which is given for nocturia and bladder training. So it won't help in case of fecal incontinence. So the main here option is to refer her to the specialist service. So what are the indications to referral to specialist service according to NICE guideline is if they have a bladder or urethral pain, if there is a benign pelvic mass, if there is associated fecal incontinence or a neurological disease, or if there is a case of a fistula and previous surgery for incontinence or a previous pelvic cancer surgery or radiation therapy. In that case, if they come with incontinence with this such history, then you are going to refer them to the specialist service. Now, here a patient presents with complaints of prolapse. And what complaints she has? She has complaints of increased frequency and incomplete voiding of urine. So she has urinary complaints, which will most likely suggest of anterior prolapse. So on examination, the POPQ score is, so this is charted on the POPQ grid, where the AABA, that is the anterior vaginal wall points, are 0. So as I said in the previously, that they should be negative in a normal woman who does not have prolapse. So we can see that C is -5, that is the cervix. D is -7, and which is normal. And the posterior vaginal wall points, that is AP, BP, are -2, which means that the posterior vaginal wall is well supported. Also, the total vaginal length is normal and the genital hiatus is 4 and perineal body is 3, which is normal. So, only the problem here is that the AA and BA are 0, that is at the level of hymen they are, means that this is a case of anterior vaginal wall prolapse. And we know that POCQ staging, there is a scores. Okay, so what stage it is? So when they are when the leading point is less like more between -1 to +1, it is a stage 2 prolapse. That is, it is stage 2 cystocele and she may need anterior repair. The B is the correct answer because it is A and BA is at the level of 0. That is between -1 to +1, which is stage 2 prolapse. So she will need stage 2 cystocele and anterior vaginal wall repair. Now, the next patient is she presents with symptoms of prolapse, but she has complaints of constipation and incomplete emptying of bowel. She has means complaints of posterior vaginal wall prolapse. And we can see on POPQ that the AA, BA are well supported. It is in the negative numbers. And the cervix and the D point is also in the minus, which means that they are above the hymen. Whereas the AP-BP point, that is on the posterior vaginal wall, they have descended and come to 0 at the level of hymen. And the rest are normal. So she wants to know what is the correct diagnosis and what is the correct surgical treatment. So here again, because it is stage at the level of 0, it is again stage 2 because it is falling between -1 to +1 of the level of hymen. It is stage 2 rectocele and she will need a posterior repair. So here the answer is C. Okay. So she will need the 0, we can see it is falling between that, and she may need a posterior vaginal wall repair. So guys, that was all about the urogynecology module YouTube RRR series. Hope you like it. So Thank you so much for attending. Goodbye.